Hi guys, I apologise in advance if the sound is bad. I noticed on my last video it wasn't very good, so hopefully this time it's a bit better. I'll talk a bit louder, but sorry if it's not, I'm not sure how to fix it. So next up we have the chest tube transport. So with the chest tube transport, this is often done in hospital or by a high level physician, and we might be transporting them from hospital to hospital, helicopter, something along those lines. So they're done often post-operatively, so or because of a pneumothorax, hemothorax, or pleural effusion, along those lines. As far as equipment provided, we need basically just PPE, maybe some tape in case of leaks, which we'll talk about later, and then we can just run through the general sort of how a tube might look. So we've got the initial site here, the insertion site, with the tube there. Then it's going to connect to our Atrium Oasis dry suction wall seal chest drain. So that tube connects to our patient here, and this is our suction tube, which is connected to wall suction there. We'll talk about that more in a second. So to start the treatment for managing this chest tube, basically it's all centered around the patient. So we want patient assessment to start. So we're going to auscultate both sides, going to be taking a full set of vital signs, palpating for subcutaneous emphysema, basically because we're worried that a tension pneumothorax may occur or will reoccur because of maybe some faulty equipment, which we'll try to troubleshoot shortly. So we've completed our patient assessment, so now we'll move on to the chest tube and the drain itself. So for starters, we'll start from top to bottom basically. So we'll go from the insertion site. So here, we just want to make sure, observe for any signs of infection or inflammation, so any redness around the skin, anything like that. We then move into making sure that our dressing is dry and intact, so it's adhering well to the skin. There's no leaks there, anything, and also on that, just making sure that this is secure. Our tube is secure. It's going to be sutured in, so just making sure that sutures are intact and everything's working well there. Lastly, just palpate around the actual dressing, making sure there's no subcutaneous emphysema or anything like that to suggest a leak. The next part to assess is the tube. So for starters, we want to make sure the tubes are lower than the patient. This will facilitate good drainage. And then while looking at it, you just want to observe for no kinks or obstructions or anything along those lines. Next, just work your way down. So here's our point where the two tubes are connected. So we just want to make sure that that's secured. It might be taped in or hopefully zip tied in. Just so making sure that's nice and tight and secure. Working your way down, make sure there's no dependent looping, and then that should lead down towards the drain where it will insert, and we will touch on that in 2 seconds. Now we've assessed the tube, we'll move to the actual drain unit itself. So we can see that it's got letters A through to E on the unit. So if we just work through each one of those, might be the easiest way. So A, first up here, is the dry suction pressure. So usually preset at minus 20 millimeters of mercury unless it's been changed by a prescribing doctor, and that's usually preset, and we won't touch that. B here is related to the tidling level. So basically the movement of a float ball during respiration. So on inhalation there'll be negative pressure, which will force the ball sort of up, and positive pressure on exhale will push the balls down. Sort of more apparent without suction, but can be seen, so you know that it's working well. C is our water seal level. So we've got a mark here where the water should meet, which is about 2 centimeters. And then what we'll see here is bubbling if there is an air leak. So you'll see it come through here, bubbling across these areas. There's marks 1 to 5 along here, and that's just our graduated markings that quantify the size of a leak, because you'll see the bubbles move across depending on how large the leak is. So that's just something to monitor and make sure that it's not leaking. So D here is our accumulation chamber. So it's connected to from the tube in the patient down into this unit. So what we'll be monitoring here is the colour and consistency of output, as well as as well as monitoring the actual output amount. So when we first get to this patient, if it hasn't been asked to put the chest drain in hospital, we're going to mark time, date, and where the actual level of output is, just so we can see over, say, every hour what the output is. E is our suction bellows, so it's related to our wall suction, which is connected up here. Wall suction, which is up here, as you can see, is at minus 80 millimeters of mercury. And what you'll see generally is an orange bellow come down and meet a triangle delta point on our E, which shows that there's sufficient suction. If for some reason it's not meeting, the suction might need to be turned up to meet that delta line. So in a nutshell, that's how we would manage and assess our chest drain and make sure everything's working effectively. So from here we can talk about a few teaching points, maybe troubleshoot a few issues. So the first area that we might have to troubleshoot is an air leak. So we know bubbling within the water chamber here may suggest an air leak, which is quantified by those graduated markings 1 to 5. So to locate the air leak, we need to work from the most proximal tip of the insertion point all the way down to the actual unit. So to do that, what we do is clamp as proximal as we can, clamp down, and then we're going to look down at the bubbling and see if it stopped. If it stopped, we know that there's probably an issue proximal to where we've clamped. So starting at the top, we're going to clamp down here for just a brief second or two. If the bubbling does stop here, we're concerned that there's an issue sort of with the most, either within the lung or within the insertion site. So we might have to consider removing the actual tube and covering the wound, the open wound, with a 3-sided occlusive dressing. Work your way down, looking at the connection here, make sure it's secured, and then sort of go a little bit lower and double check, see if bubbling stops. If it keeps going, then you want to just keep working down, sort of increment, until you get to the bottom here at the insertion of the actual unit. If you clamp above and there's still bubbling, then we're concerned that the unit is causing the trouble with the air leak. So this means that it might need to be replaced with a secondary unit. Worst comes to worst in this situation, you can actually remove this tube and place it into a beaker of sterile water or something along those lines, just to create that one-way water seal again. Another issue that may occur is dislodgement of the chest tube. So similar to before, all we're going to do there is just cover a sterile occlusive 3-sided dressing there. So that covers our chest tube management during transport. The only thing to add is that if we have an issue with say a tension pneumothorax has developed and we found that in our observations or patient assessment, we may need to either remove the actual chest tube and cover it with the dressings as we've talked about, or you can look to insert a complete needle thoracostomy to remove that tension as a temporary measure.